She serves as a staff intensivist in the medical surgical neuro ICU at Toronto Western Hospital with research affiliation to the Keenan Research Center at St. Michael Hospital. Her academic work focused on respiratory physiology and mechanical ventilation, with a particular emphasis on the patient-ventilator interactions, including the pathophysiology and clinical impact of abnormal interaction on lung and diaphragm function, and additional interest in advanced monitoring tools and sleep physiology. She is speaking about the topic respiratory efforts. What is the impact of ventilation more? Over to you, Dr.
Thank you very much to you for the kind introduction and the organizers for inviting me. It's really nice to see all the speakers gathered and the way you organize in different time zones. Okay, I will walk you through a little bit of a physiological journey to see if we can understand together how patient interacts with the ventilator according to the main modes of ventilation, okay, and how this might impact at least immediate physiological consequences. So these are my disclosure of some of the funds I received for research. And we're going to start a little bit about what are the physiological consequences of breathing effort in general, and then focusing specifically on what happens to the lung, which is where I will focus my talk today, okay? So starting on the lung, we know from the seminal studies from Takashi Yoshida that in animal models, when you put them to breathe spontaneously, and they have underlying mild lung injury, the presence on the left upper corner, the presence of inspiratory effort actually might be beneficial. In patients with severe lung injury, this is an animal model, addition of strong spontaneous breathing efforts can worsen lung injury. And what's the physiological principle or the physiological rationale for understanding why this happens? So one of the mechanisms, and we'll see this in detail in the next few slides, is that when we are thinking of assisted mechanical ventilation, so the positive pressure delivered by the ventilator and the negative pressure generated by the patient, the total pressure applied to the respiratory system is the sum of the two, the airway pressure, so positive pressure delivered by the ventilator, and negative pressure generated by the patient. But to go a little bit, this is like the general idea of what happens in the lung. But it's good to always go to the general idea that there are many other things that are happening when we breathe spontaneously. The other thing that happens is that you do have hemodynamic consequences. So strong breathing effort or low breathing effort plus the sedation and sometimes neuromuscular blocking agents do have impact on cardiovascular function. And this impacts not only the heart itself because of coronary perfusion, but also big organs like the brain and the kidneys. Additionally, thinking about what's happening inside the blood, so the idea of the blood as a carrier of oxygen to the different organs, when we breathe spontaneously, particularly when we have very strong breathing efforts, oxygen consumption is primarily from the respiratory muscles. And therefore that, not only through the hemodynamic consequences, but also directly through increased extraction of oxygen from the respiratory muscles, you might end up having decreased oxygen supply to the different organs that can in turn lead to further systemic inflammation, and also systemic inflammation impair the uptake of oxygen to the different. And then more recently, a lot of emphasis on the effect of breathing effort on the diaphragm itself, on the diaphragm and other respiratory muscle cells, but primarily the diaphragm. So very low, absent of effort, you have atrophy. And then when you have breathing effort, within acceptable range, so that individual patient preserve respiratory muscle structure and function. But then possibility that very strong breathing effort, excessively strong, some potential immediate sarcometic disruption and immediate dysfunction, and as compared to acceptable breathing effort. This is to be a general overview that breathing efforts have consequences. And I'm going to focus specifically a little bit more step forward to the pathophysiology of patients self-inflicted lung injury, because how patient interacts with the mode actually impact these mechanisms. So as a review of patient self-inflicted lung injury, you have an initial lung injury here. So you have the initial lung injury, you have capillary leak because of the inflammation, etc., that generates lung edema. And the problem with that is that lung edema worsens both gas exchange and lung mechanics, and that in itself not only can be potentially deleterious for the patient, but also can generate an increase in respiratory drive and effort, high respiratory drive and effort. So that high respiratory drive and effort renders these mechanisms of patient self-inflicted lung injury. And we here in this review, they put 4, but I grouped them in 3. I put them in a slightly different, but in a general idea. So it's the increasing global tidal volume and excess stress and strain, the increasing regional distribution of overdistension, and the decrease in alveolar pressure. And we'll see these 3 in detail. Okay, all secondary to the decrease in pleural pressure. So all of these mechanisms can potentially worsen capillary leak and lung edema through worsened structural lung injury. And that perpetuates the vicious circle. Okay, so now going specifically into these mechanisms of potential patient self-inflicted lung injury. So the first one is the excess stress and strain. So what are we talking about when we...
Lo que sí, si es que está muy malita mañana, yo le voy a ayudar con el soporte de... Yo consigo una cánula nasal de alto flujo para ayudar.
I don't know if someone can mute, maybe Edwin, or if you can mute yourself.
No,
No worries.
please carry on. I will just see.
Okay, so the first mechanism I already alluded to, but I want you to see it in detail because it's important for what's coming. So we have the positive pressure delivered by the ventilator and the negative pressure generated by the patient.
Le cambia el antibiótico si es que está sospechando que es una neumonía.
Sorry, can you mute Edwin?
Yeah,
I don't know if the administrator...
Puede que siga haciendo las bolitas.
We can hear you.
Yeah, okay. Okay, so the positive pressure delivered by the ventilator and the negative pressure generated by the patient.
Si están pensando en neumonía intrahospitalaria, que le cambie.
When we talk about the total pressure delivered to the patient, is the sum of the two, positive and negative, and this is what we call the total driving transpulmonary pressure. Okay, and that generates a certain tidal volume, as you see here on the flow tracing: positive insufflation, negative exhalation. So when we talk about the total driving transpulmonary pressure, the potential for harm induced by that is irrespective of where the pressure is coming. If it's coming from higher positive pressure from the ventilator and let's say intermediate effort from the patient, or if we switch, so we have very little airway pressure from the patient and stronger negative deflection from, very small positive pressure from the ventilator and stronger inspiratory effort from the patient, rendering the same total pressure applied to the respiratory system, okay, on the right. So this is what we call excess stress, because there's that deformation of the lung parenchyma due to the excess pressure, and strain because we have a higher tidal volume in a global manner, okay? And there's been observational data showing that higher values of these global measures of excess stress and strain are associated with worse clinical outcome. Okay, in this study, for example, the association with ICU mortality. An addition to this is that when you have heterogeneous lung injury, there is distribution of air from the well-aerated areas to the less well-aerated areas. And this is what we call Pendeluft, okay? So on top of the air that you're receiving from the ventilator, you also get redistribution of air from these very well-aerated to less well-aerated areas, and that can increase the regional deformation of the lung, okay? When we talk about strain specifically, we are talking about the potential for harm induced by changes in volume. The other one was related to pressure. And is its volume harmful? Well, we know this since the original studies done to address ventilator-induced lung injury. And these are the lungs of rabbits used in the original experiments from the 1980s, where you see the first lung is healthy lung, the second lung in the middle is lung exposed to injurious ventilation in the form of high volume for a short time, and the one on the right is high volume for a long time, okay? Well, these were done with ventilators, okay? But the interesting thing about these experiments is that their mechanical supply of both positive pressure or mechanical supply of insufflation was done with two different models. One, if you see here, is the first bar is high pressure and high volume. So this is the typical positive pressure ventilation. You give positive pressure, there is a higher volume. The second bar is high volume, but with low pressure, okay? And how did they do that? So they did this by a model similar to what we call the iron lung. So it's I put this because this is from the polio epidemic when kids had polio and they put them in the iron lungs, but one of the polio epidemics. But in this case, it was animal models where they put inside a chamber and they generated negative pressure, okay, from outside the chest to generate this high tidal volume. And you see that this negative pressure, when you increase tidal volume, can generate the same or even worsened amount of lung injury that we see on the y-axis as compared to generating the same tidal volume but with positive pressure. And why is this relevant for this talk is because this is how our respiratory muscles work, okay? So they contract, okay, the diaphragm descends and the chest wall expands, and that generates a decrease in pleural pressure surrounding the lungs, which generates a gradient that makes the air go into the patient, okay? So we talked about the first, let's say, three mechanisms: excess global stress, excess regional stress, and excess global strain, so excessive volume. The last one is a little bit more specific of spontaneous breathing. And in order to understand, we need to go back to understanding a little bit of basic mechanics of the respiratory system. So the respiratory system, we have a elastic component, which is the lung parenchyma itself, and then a resistive component, which is the flow of air through the airways, okay? And inside these lungs, we have the alveoli, okay? So if we want to measure the alveolar pressure, so what's happening here, we have to somehow remove the resistive component that modifies the pressure when the air is flowing through the airways, okay? So bottom line, the alveolar pressure is the airway pressure that we can measure here, airway opening, minus the pressure generated by the friction of air through the airways, okay? What's the correlate of this? The correlate of this is that we said that in these two scenarios, so high positive pressure, intermediate effort, we have X global stress, so X amount of total pressure applied to the respiratory system. And then we have a different scenario with small positive pressure but strong negative pressure generated by the patient. In these two scenarios, if we calculate the alveolar pressure in both scenarios is very, very different, okay? So the way to calculate is we subtract from the airway pressure the resistive pressure, so the pressure generated by the friction of air through the tubings. How do we do that? We multiply the resistance of the patient by the flow rate. And then if we do the same in a context of a small amount of positive pressure but very strong negative pressure and a higher peak inspiratory flow, if we subtract this from this scenario, you see that the alveolar pressure, which is this dotted line, is much lower, okay? And what is the problem with that? Well, the problem is that the alveolar pressure goes very low, okay? It can drop, the alveolar pressure goes very low. It can drop below the end expiratory positive pressure delivered by the ventilator, okay? This is a physiological study done some time ago, 2016, by the group of Bellani. So what they did is they grabbed patients that were first on controlled ventilation, and then when they were ready for pressure support, they also measured them on pressure support, and they measured resistance during controlled mechanical ventilation, so that then when they were on pressure support, they could calculate alveolar pressure. They put the patients on high levels of pressure support and then small effort and then medium levels and low levels, doing like this experiment going from the right picture to the left picture. So high support, low support, and the effort increase. And they calculate the alveolar pressure. And they saw that when the effort was very high with small positive pressure, the combination of these two factors rendered a low alveolar pressure that was actually even below the peak value, which is what we see here on the left picture. Okay. And what is the ultimate issue with that? Is that if your alveolar pressure is lower than your capillary pressure at end expiration, then there will be a pressure gradient in the alveolo-capillary membrane that favors further water within the interstitial space and the alveolus, okay? And worsen edema and potentially even alveolo-capillary leak, okay? So this is how it can result in one of the mechanisms of lung injury. I was always interested in this phenomenon because when I came to I was originally trained in Argentina, and then I came to Toronto. So it was said that in Toronto, respiratory therapists were trying to keep the tidal volume, as you see here, within a preset range, even when the patients were switched to pressure control with or assisted modes or spontaneous modes. So let's say in this case, for example, the RT was trying to keep the patient in less than, let's say, 500 mLs. Okay, and in order to do that, they would decrease the amount of support progressively. Okay. What's the problem with that? Is sometimes you end up having these recordings. Okay, this is volume control ventilation with the set tidal volume. You see here 400, but actually the patient is getting 500. So they're trying to get 400. And the airway pressure, which is the upper tracing, instead of going upwards, which is what you would expect if the patient was on volume control, it goes downward. So the decrease in alveolar pressure is so extreme that you even see it on the airway pressure tracing, okay? And I was thinking, okay, tidal volume is relatively okay, but that cannot be good for the patient, okay? So that's a little bit of the motivation. So we did a study, a physiological study from a large observational cohort study with detailed physiological study where we try to address what is the influence of the magnitude of effort on the different mechanisms of potentially patient self-inflicted lung injury? So excess global stress driving transalveolar pressure, strain, tidal volume, and and this negative alveolar pressure, or when alveolar pressure falls below peak, okay? And how this can be modified by the mode of ventilation, okay? And then once we address that, so we try to check if actually these mechanisms modified by the magnitude of effort do ultimately modify a physiological outcome related to a patient self-inflicted lung injury, which can be oxygenation or lung compliance, okay? So a little bit of how the modes work, and this is just a review. We have the positive pressure from the ventilator, okay? And the pressure applied to the respiratory system has a resistive component and an elastic component. The resistive component, so the friction of air through the turbines, depends on the flow rate and the resistance, and the elastic component on the magnitude of the inflection, so the volume and how elastic that body is. Okay, sorry. When we talk about the different modes of ventilation and the patient is not doing any breathing effort, each mode will control some of these variables of what we call the equation of motion, but not the others, okay? The others will be a result of the interaction between the mode and the patient's mechanics when the patient is passive. So on pressure-limited modes, we control the pressure, and the resulting signal is the volume, as we see on the flow tracing over time. And in volume control, what we are controlling is the flow, and the resulting signal is the pressure. So if there's a change in mechanics, for example, in this case, in these two cases, where we see here a very high elastance, so you see that the filling of the lung is very quick, and the volume becomes small. And in the second case, we have high resistance. So what we see is a difference between the peak and the plateau pressure when we generate a pulse, okay? So a colleague of mine some time ago, he's from Nataparitayamai from Thailand, he did a systematic review to see if there were difference in outcomes between the different modes of ventilation, primarily pressure regulated or flow regulated or volume control. And he found that on big outcomes like ICU mortality, length of stay, there was absolutely no difference between pressure support, pressure limited and flow limited or volume control ventilation, okay? Globally, okay? And he restricted to, big outcomes, as expected, okay? Other surrogate outcomes, there was also no difference. But if we look more carefully about that systematic review, we see that there is a difference with the work of breathing that the patients do when they're in one mode versus the other mode, okay? So if the peak inspiratory flow is insufficient on volume control, the pressure control ventilation renders a smaller inspiratory effort, okay? If the peak inspiratory flow is the same between the two modes, there's no difference in work of breathing. So why is that? We will see at the end of the session. So the difference when the patient breathes spontaneously is on top of this equation of motion, we have the respiratory muscles. So you have the positive pressure from the ventilator and the negative pressure generated by the patient. So now it becomes a little bit more complex, okay? Because the ventilator only controls one variable. For example, volume control controls the flow, okay? And the resulting pressure will be a result of the interaction with not only the resistance and the elastance of the patient, but also with the effort that the patient does, okay? And the same for the pressure regulated modes. So the pressure regulated modes control only the pressure, but none of the other variables. So the resulting flow will depend on the other variables. Not only the resulting flow, but also what happens at the alveolar level will depend on the other variables. Okay. So in this physiological study, what we did is we grabbed patients with acute hypoxemic respiratory failure that had moderate to severe failure, so a PF ratio less than 200, were on continuous sedation on inclusion. And for this analysis, we selected 60 patients. Okay, let's see how the measurements were. So the patients were intubated within 7 days of fulfilling criteria to moderate to severe acute hypoxemic respiratory failure. They were enrolled in the study. In this study, we collected recordings 3 times per day. Okay, from day 1 to day 7. Okay, in the morning, afternoon, and evening. And for this analysis that I'm going to show you, we selected passive recordings that had, we selected recordings that had active breathing with a previous recording that was completely passive. Okay, they had to have some breathing effort, but on the previous recording, the patient was completely passive. When I'm talking about recording, it's like the same that you see on the ventilator screen with the flow, the airway pressure. And we had the addition of esophageal pressure as a surrogate for pleural pressure. Okay. In total, 60 patients, more than 500 recordings in total. Okay, and lots of respiratory cycles. From these recordings, airway pressure, flow, and esophageal pressure, we calculated the different parameters to measure the stress, the strain, and the drop in alveolar pressure. Okay? So to calculate the alveolar pressure, we had to subtract the resistive component. So we calculated a tracing that was the alveolar pressure, which was the airway pressure minus the resistive pressure. And the resistive pressure we calculated by multiplying the flow rate times the resistance of the patient. Okay? And you see how already here you have the alveolar pressure, it's always lower than the airway pressure. And when the patient has a strong breathing effort, you see that here it drops even below PEEP. The other important thing is the other way to subtract the resistive pressure is to generate an end inspiratory pause. You see here flow is positive, then there is a pause, and you see that during the pause, the alveolar pressure equals the airway pressure. So the common thing that we do in our clinical practice is just to generate a pause. But we wanted to have the continuous alveolar pressure because sometimes the effort, sometimes when you do a pause, the effort stops. So we cannot see what's the effect of effort on alveolar pressure. The second thing that we calculated was the transpulmonary pressure, which is the pressure across the lung parenchyma, okay? Which is the difference between what happens the airway pressure, what happens inside the airways versus what happens outside the airway, which is the pleural pressure measured by the esophageal pressure. And this difference is the transpulmonary pressure. And finally, we calculated what we call the transalveolar pressure, which is to subtract the resistive component from the transpulmonary pressure. Ultimately, we calculated the total driving transpulmonary pressure and the difference between alveolar pressure and PEEP. So going to the results, what we did then is see how much the muscular pressure modified each of these parameters. So the effort modified each of these parameters according to the mode of ventilation. So on pressure regulated modes, each line it was one recording, the bright lines. And then the dark lines are the summary, so the mean values. So as effort increase, the total strain increase in pressure regulated modes because the pressure, the ventilator is not controlling the volume, it's controlling the pressure. The same with the driving transalveolar pressure. The red lines is when the patients have breath stocking. And you see it also increase and there's not a huge difference. Okay. The big difference appears with volume control. Okay. You see when the effort increase, tidal volume as expected does not increase a lot. You see the black line does not increase a lot. But we were surprised to see two things. One is that when the effort is extreme, you see that it does increase a little bit. And why is that? Some ventilators with extreme effort on volume control, they open the inspiratory valve and allow a little bit more volume, okay? And when you have breath stacking, for sure, you see the red line, with strong efforts, the volume increase. Same with the total stress, okay? What happens with the alveolar pressure, which is the one on the lower panel, okay? As the effort increases, the alveolar pressure becomes more negative. And this is steeper, even more important than what happens with the pressure regulated modes, okay? Why is that? Because on volume control, you're limiting the flow, okay? So the resistive component is bigger, and then when you subtract the resisting component from the airway pressure, you get a smaller value. This becomes, this is on the A panel. I superimposed all the tracings for all the lines for each of the modes. And then the last thing that we did is to see actually what was the reason for this. And what we calculated, it was the ratio between the pressure generated by the patient, P mass, and the positive pressure generated by the ventilator, okay? And what we found is when we do this ratio, we see that volume control and pressure control behave equally when it comes to the relationship between the ratio and the alveolar pressure. So at the bottom line is that what happens is on volume control, the stronger the effort, the smaller is the positive pressure from the ventilator, okay? And that's the reason why the alveolar pressure drops so profoundly, okay? Which is what's happening here, okay? And the final thing that we did was to see if this excess stress and strain and alveolar pressure dropping below PIP had an impact on physiological outcomes. So what we did is we did the mean value for these parameters on each day, and we checked how this impacted the difference in SF ratio and lung compliance between the subsequent day and this day. The idea is, did the oxygenation improve when the patients were exposed to this high driving transalveolar pressure and very low alveolar pressure, or did it worsen? And what we found, these graphs are a little bit complex, but what we found is when the alveolar pressure was negative, this quadrant here, the difference in SF ratio between one day and the following day was also negative. So that means that the oxygenation worsened, okay? And when the driving transalveolar, despite the driving transalveolar pressure being low, so that means low excess stress, so low stress, if the alveolar pressure was negative, again, there was worsening oxygenation in the form of decreased SF ratio, negative SF ratio difference. And then regarding the changes in lung compliance, if you see all patients together, the excess stress increased driving transalveolar pressure. There was no change in compliance with higher driving transalveolar pressure, except in patients where the increase in driving transalveolar pressure was due to inspiratory effort, which is this negative. So the excess contribution of inspiratory effort to the overall stress might have a negative consequence on lung compliance, okay? So to finish, I'm sorry for the big delay, and so with strong inspiratory effort in general is associated with excess stress, strain, and a drop in alveolar pressure, okay? These three mechanisms are associated with a subsequent decrease in oxygenation and lung compliance. And the difference between the modes is the following. On pressure-limited modes, the increase in stress and strain is directly proportional to the magnitude of effort, okay? In volume control, the relationship is a little bit more complex. The stress and strain is often within the established limits, okay? But not always. If the effort is excessive, then some ventilators open the valve and they will give you more volume and more stress and strain. When there is breath stacking, of course, there is more volume. Regarding alveolar pressure, with the same volume, you get an effort, you get lower alveolar pressure on volume control. Okay, and this is dependent on the relationship between how much positive pressure the ventilator gives versus negative pressure. And with this, I finish. I thank you. And I also invite you, if you want to check our website, mechanicalventilation.ca, to check for our annual online and in-person course in Toronto. And thank you again for your invitation. And I don't know if there are time to questions.
Thank you, Dr. Irene. Such an elaborative talk about, especially it is giving the insight of our viewer. The traditional way of lung protective ventilation is not really lung protective ventilation, because that addresses only the airway pressures and the volume. But the things becomes more complex when the patient participation is started and the inspiratory effort is being generated. Though the screen showing less airway pressure, driving pressure is in your favor, but actually it is a harming, and some machine may allow to increase the unregulated tidal volume in response to the expiration. That's the bottom line. I think our viewer understood this, all the details, and the way you elaborated these mechanisms, along with the a comparison of the different modes of ventilation. And even we can't get away with the dual mode of choosing the dual mode of ventilation. That would be a complete
Yes.
I don't see any question from audience. Otherwise, we can close this session.
Yeah. So wonderful, Dr. Irene, a lot of physiology there, and your experimental work at University of Toronto. Congratulations. And there are no questions, because I think that was a very heavy piece of physiology. Thank you very much, Dr. Irene. We really appreciate that. And Dr. Jitendra, shall we move on then?
Yeah, we should move. Thank you, Dr. Irene.